Hello, my name is Dr. Jack Lambert, and I'm a professor of medicine and infectious disease in the Mater Misericordiae Hospital and the University College Dublin in Dublin, Ireland. The title of my presentation is Congenital Lyme and Co-Infections, and I put these slides together as part of the Physicians CME platform supported by Invisible International. I disclose no conflicts. I will not be discussing off-label use of medications. The objectives of this presentation is to describe the differing perinatal outcomes in vertical transmission of borreliosis. Borreliosis is the bacteria commonly known as Lyme disease. We will list the tick-borne pathogens that can be perinatally transmitted to the neonate. We will discuss the risks to infant from perinatal acquired relapsing fever, borreliosis, another type of borreliosis, uncommon in today, but quite common and well studied in Africa. So when you're dealing with a mother, you're dealing with a complex partnership of the mother, the baby, and the placenta. So there's a complex interaction of the maternal-fetal interface, which is really poorly understood. There's a certain number of immune changes in pregnancy, and immune modulation in pregnancy includes changes in CD8 cells, decreasing cytotoxic T cells, and a shift from a Th1 to Th2 helper cells, all which increase susceptibility to infection. This change is necessary so that the mother can keep the baby. The role of the placenta is both a protective barrier from infection, but also for maternal immune recognition, while also supplying the fetus with all of the essential nutrition for human development, really needs more research. So, vertical transplacental transmission of disease. Transmission of infections can occur at many different times. A vertically transmitted infection is caused by active pathogens such as bacteria or viruses that are transmitted directly from the mother to the embryo, fetus, or the baby during childbirth. The term congenital gestational infection can be used if the vertically transmitted infection persists in the baby after childbirth, causing postnatal infection. Clinical evidence of infection may be seen at birth, may be seen shortly afterwards in the neonatal or early newborn period, or it may not be seen till years later. This latency, the absence or pause of symptoms is the definition of latency, has been well described with other congenital infections. And you all are familiar with other congenital infections, CMV, toxoplasmosis, the classic torch infections that you learn about in medical school. So there's different outcomes depending upon the infection. If there's exposure, there may be minor self-limiting illness. There could be, on the other end of the spectrum, pregnancy loss from spontaneous abortion. There can be invasive fetal infection. There can be congenital syndromes. Thus, the timing of fetal infection in utero may determine the extent of disease manifestations and the outcome for the newborn or of the unborn child. So, as stated, there are different outcomes in pregnancy, wide variations in outcomes depending upon the timing of infection, the type of infection, the interaction between the infecting organism and the immune system, and indeed certain host factors, including the placenta. Peri and postpartum infections may represent mucosal exposure, for example, at the time of delivery when the baby comes through the birth canal, or it may represent breastfeeding. Infections occurring in this period may not manifest immediately, but not show up till later in childhood or even beyond. So the challenge now is we're dealing with Lyme disease, Borrelia burgdorferi, and there's been lots of questions as to whether this bacteria can be transmitted in the womb, and can cause congenital disease and adverse outcomes. And this is a slide just demonstrating Borrelia in a photo taken from early studies of human amniotic membrane from State University of New York. And one of the first individuals to present data on borreliosis in pregnancy was the fellow who was Borrelia burgdorferi was named Willy Burgdorfer, one of the pioneers of Lyme disease. And in a lecture that he gave, the R.R. Parker Memorial Address, he quoted, "We have now found a spirochete capable of spreading transplacentally to the organs of the fetus, causing congenital heart disease and possible death of the infant." And this was published in the Review of Infectious Disease going back to 1986. Similarly, if you look in the pediatric literature, you'll see that there have been cases of children born with unusual rashes that upon further testing was found to be Lyme disease. And this slide here raises the question, a lesion due to spirochetal infection, a case of congenital Lyme borreliosis. And this paper by Trevisan et al. Goes through describing a case where the baby presented at 3 years of age with a relapsing rash, no history of a tick bite. There was a 32-year-old mother who actually didn't recall a tick bite and had no symptoms in pregnancy. The baby was negative at 9 months of Lyme serology, and then at 13 months became positive. And then when the skins were biopsied, research studies, you can actually do a PCR and actually isolate the organism itself. B. burgdorferi was isolated and detected by PCR from the skin sample. And despite repeated course of oral antibiotics, these lesions recurred multiple times over the following 3 years. And the child was retreated each time. The rash went away and came back again. And by age 4, there were no further lesions documented. So the author suggested then that congenital borreliosis and cutaneous manifestations of congenital spirochetosis was the cause of this child's disease. But it goes to show you that it's not that simple. You can have a negative antibody test and be positive for Lyme. And despite treatment for Lyme, you can have relapse of Lyme. So it's not always easy to diagnose and easy to treat. Is there data to support that Lyme, crosses the placenta and can cause disease in pregnancy? And this is just a summary of the tick-borne disease working group 2018 report to Congress. And they state transplacental infection of the human fetus has been recognized for relapsing fever borreliosis, as well as for Lyme disease, babesiosis, and certain other infections. Pregnancy poses a particular challenge for treatment because few antimicrobials have been approved that are safe to use during pregnancy. Additional research into appropriate treatment options are needed. In terms of pregnant women, gestational tick-borne disease can be transmitted to the unborn child in utero and has the potential to cause premature labor and fetal death. One priority research area involves the risk of maternal fetal transmission for various tick-borne diseases, as well as how to treat this population if exposed during pregnancy and needing treatment while pregnant. And one of the challenges, as I stated before, the reliance on currently available serological tests may not be appropriate. Moreover, hormonal changes during pregnancy can lead to changes in immune function that may affect the detection of clinical or laboratory findings. So very often Lyme disease is masked in pregnancy in the pregnant woman. It may be milder. And then after delivery, when the immune system returns, the disease can flare up in the woman. This is a report from the Canadian government that discusses Lyme disease during pregnancy. And from their summary, they say there is not enough evidence to confirm that Lyme disease during pregnancy has an adverse effect on the fetus. In addition, no adverse effect for the fetus has been observed when pregnant women receive appropriate antibiotic treatment for Lyme disease. Evidence to date in case reports, which study individual cases, case reports have raised the possibility that Lyme disease in pregnant women may have an adverse outcome for the fetus or newborn. However, it's not clear if and how the adverse outcomes were caused by the Lyme disease bacteria. There's a certain number of epidemiological studies. Epidemiological studies have not found a consistently higher rate of adverse outcomes of pregnancy in women with or at risk of Lyme disease compared to pregnant women who are not infected or at risk. These studies cannot rule out the occurrence of adverse outcomes of Lyme disease in pregnancy. And they summarize, further research is required to better understand if there may be adverse effects of Lyme disease during pregnancy. So there seems to be some question and limited data in the medical literature. And there seems to be an argument from different groups as to whether Lyme disease does occur in pregnancy, what are the consequences of that? And there indeed are only limited studies that have been done, really pushing the question that why are we not doing further research in this area? So besides Lyme disease, there's other tick-borne infections that can transmit in pregnancy from the mother to the child. First, ehrlichiosis in pregnancy. So ehrlichiosis is a gram-negative obligate organism, and this includes Anaplasma ehrlichia, which are part of the Rickettsia group of organisms. And one of the diseases they cause is human granulocytic anaplasmosis. And this causes a flu-like illness. Patients often present with low white cells. You can actually see inclusions in the white cells. And there's cases of miscarriage that have been reported, and vertical transmission has been reported. Human monocytic ehrlichiosis, where you get intracellular invasion of organisms, is also associated with adverse outcomes. But this is not well described and just reported in very small number of case reports worldwide. This is a presentation, a case report where it describes perinatal transmission documented in one neonate. So this is human granulocytic anaplasmosis during pregnancy. And it reports then case series and literature review. So it does appear that it does happen, but it doesn't seem to be a lot of collection of data on tick-borne infections in pregnancy, including human ehrlichiosis. Another infection spread by ticks is babesiosis. Babesiosis is a protozoan. There's many different species. 5 species have been confirmed as human pathogens. And most common in the USA is the species B. microte, and in United States, and B. divergens in the European Union. It appears to be more common in immunocompromised patients, including those who are splenectomized. So pregnant women are thought to be of higher risk. And it seems that if the pregnant woman develops babesiosis in pregnancy, they can develop the HELP syndrome. A congenital syndrome has been suggested with fever, thrombocytopenia, and anemia. And this is just a case presented from the CDC Disease Control and Prevention from a number of years ago, 2012. And they report vertical transmission of Rickettsia microte, United States. And their abstract really just mentions that the babesiosis in the United States is usually acquired from tick-borne infection or through blood transfusion. And they report a case of babesiosis in an infant in whom vertical transmission was suggested by evidence of Babesia antibodies in the heel stick sample, and was confirmed by PCR detection in the infant. Another infection that is thought to transmit in pregnancy is tick-borne encephalitis. Now, tick-borne encephalitis is very common in Eastern Europe, common in Scandinavia, Sweden, Ukraine, other parts of Eastern Europe, and indeed, there's a vaccine for tick-borne encephalitis that is given in Eastern Europe. This tick-borne encephalitis is a Eurotropic flavivirus. So there have been a case report of infections in the third trimester of pregnancy, which really resulted in self-limiting infection. So there doesn't seem to be severe consequences to the infant in pregnancy when the mother is infected with tick-borne encephalitis. There's cases in non-pregnant individuals where the symptoms classically are non-specific flu, followed by neurological sequelae, including meningitis, myelitis, encephalitis, and paralysis. But like I said, in pregnancy, those complications have not been seen. And as mentioned before, a vaccine is available and should be considered in endemic areas. And the endemic areas within the European Union are in the eastern parts of the European Union and in Scandinavia. Relapsing fever in pregnancy. This is an infection, a type of Borrelia that is more commonly found in most of the studies have been reported for Africa. Although there have been a few cases, very few cases reported in Europe and North America. So relapsing fever, borreliosis are part of a number of different Borrelia species that have been identified as stated in various geographic regions. It's quite a severe disease, infectious disease, worldwide. It causes up to 10 to 15% of neonatal deaths worldwide. And some of these are tick-borne fever induced. In studies that have been reported mostly out of Africa, they're associated with decreased birth weight, preterm delivery, or alternatively severe damage and miscarriage or neonatal death. Animal studies have shown in mice impaired fetal circulation, direct invasion of the placenta, and intrauterine growth retardation in the mice fetuses. This is a study reported in Acta Obstetrics Gynecology, Scandinavia, going back to 1997. And they did a case control study of 137 pregnant women, a rural hospital in Tanzania. In that, the perinatal mortality was 436,000 births. The total loss in pregnancy was 475 per 1,000. And the case fatality rate overall in pregnant women was 1.5%. There was a higher rate of spirochetemia in pregnant women compared to non-pregnant controls. And perinatal death was related to low birth weight and low gestational age, with 9 of 45 newborns who delivered dying, a rate that was 12-fold increase from the normal rate at the hospital studied. And the relapse rate was 3.6 in those treated. So we don't have this kind of data on Lyme disease in pregnancy. This is a similar infection, relapsing fever, caused by a Borrelia organism that is similar but different than the organism of Lyme disease, which in America is Borrelia burgdorferi sensu stricto. But it's the best data we have, and it does support that spirochetes, Borrelia spirochetes, can cause adverse outcomes in certain populations. This is another publication coming out of Canada, and this is tick-borne relapsing fever in pregnancy. And this presents, it's just a case report where it presents a 31-week gestation Canadian who presented to the Toronto Hospital with a 2-day history of fever, chills, nausea, vomiting, and myalgias. Her symptoms had begun 2 years after returning from a camping trip in southern British Columbia. She developed anemia, thrombocytopenia. The spirochetes were identified in the blood smear. She developed a Jarick-Hertzheimer reaction in response to the antibiotics. She developed the HELP syndrome, and HELP, as you know, stands for hemolysis, elevated liver function tests, and low platelets. She then developed heart problems with left ventricular hypokinesis with an ejection fraction of the heart of 40%. After ICU stabilization, she survived and delivered a healthy baby 1 month later. And this is just a picture where you can actually see the organisms in around the red cells, tick-borne relapsing fever in a mother and newborn infant. And this is from Colorado, 2011, and it was published in the MMWR in 2012. So you can actually identify these organisms on blood smear. Rickettsia disease in pregnancy. In the US, the most common rickettsial infection is Rocky Mountain spotted fever. And it's probably one of the most pathogenic rickettsial infections in all populations. It causes a febrile illness with mortalities as high as 30% without treatment. In pregnancy, the rash is often missed, and the outcomes are similarly not treated. Of note, no cases of vertical transmission are reported. The risk for Rocky Mountain spotted fever and similar diseases is actually maternal and fetal death. Another infection thought coming from ticks, Bartonella, also coming from sandflies, and some recent data that they could come from mosquitoes as well. Bartonella in pregnancy. Like I said, classically from fleas, lice, and flies, but also ticks are implicated, and sandflies, and most recently, even mosquitoes. In pregnancy, there's a high mortality, miscarriage, preterm birth, and fetal deaths, which are in South America. It's called Carrion's disease. And if a woman is pregnant and gets Carrion's disease, there's a high fetal mortality and preterm death. And there's really actually only one case of vertical transmission. Most of the disease occurs from maternal death. And this is just a case report of evidence of perinatal transmission of Bartonella vinsonii and Henselae to a child. And this was reported in North Carolina. And the story here is a baby delivering to a mother and Bartonella being detected by molecular techniques. So this is one of the few studies coming out of the medical literature supporting transmission of Bartonella from mother to child. So what I've done in the first part of this presentation is just to raise the issue of tick-borne infections in pregnancy. And the most common one that we talk about is Lyme disease, but there are other bacteria and viruses that spread from tick-borne infections. So tick-borne infections in pregnancy may be much more common than we understand. There is no systemic mechanism to record these infections in pregnancy and the outcomes of the infant born to these infected women. We will be talking in the next presentation about the challenge that has been ongoing on raising the issue that congenital Lyme is indeed a real entity and needs recognition as a standalone ICD-11 code, because it's going to be important that we have this to be able to follow pregnant women who are infected with tick-borne infection, following them through pregnancy, following their outcomes through delivery, and following the babies after delivery to look at the true consequences of tick-borne infections, Lyme disease, Bartonella, ehrlichiosis, babesiosis in pregnancy. But at the present time, we don't have a good mechanism to follow these pregnant women through delivery and the postpartum period. And only by systematically studying congenital Borrelia infection and these other tick-borne infections from pregnancy through delivery and follow-up will we be able to advance our understanding of this condition.